about work that she's doing. But I think generally as teams that are designed, end user design, there's different ways of saying that it has really made its way to implementation science as a way of, I think different strategies in their regions, and also engaging the end user, right? So in this case, it's the provider. So we want to make sure that we are creating something that a provider will find useful and helpful and engaging. And so I think that's a core tool, the toolbox of implementation science to develop strategies. So, thank you.
Unfortunately, Dr. Chandler was not able to join us today to take illness. So we miss her perspective and valuable work. She's with us in spirit. I know it was very much part of planning the event. So we thank her for that. We are really appreciative who was already coming and supporting the event, but actually now has an opportunity to share some of her amazing work in this space. Dr. Sales is a cert in the department of School of Emory. She is also co-director of the Prevention and Implementation Sciences Core of the Emory Satcher for AIDS Research and director of the Emory CBAR Implementation Science. That's other hubs, and we have been a developmental psychologist by training, and her research for the past 15 years has focused on improving mental and sexual outcomes of in the southern United States through the development and delivery of evidence-based interventions in community, schools, and safety net health clinics. She's currently the principal investigator for 3 NIH-funded implementation science projects focused on integrating new evidence-based practices, including PrEP and trauma-informed care, into safety net family planning clinics and Ryan White funded HIV Southern US. So, Dr. Sales, thank you so much for being willing to step in, having a presentation ready, and we're very good to hear from you. Thank you.
Thank you so much for having me today. I was excited to be here, and now I'm a little anxious because I could. Thank you. So I'm going to talk to you today. Big thank you, Dr. Bonner, for setting up some of the work that I'm going to share with you today. And I'm just delighted to potentially address a couple of the questions that have come up so far and highlight the use of how we're innovating on an implementation science framework that didn't actually include a community element to it, and how we're doing that in this project. So I will get to it. I'm going to just start off by saying, this is some work that we have had funded as part of the ending the HIV epidemic funding. So we received a 1-year award that was administered through an administrative supplement to the CBAR in 2019. So the first year that they gave out these awards. And we were fortunate to be able to then quickly utilize the findings from that project, which I'm going to share, term implementation award, which I'm going to share some of the ongoing work that we're doing with that project. This is implementation science and just research in general. Is no one's solo endeavor. It takes a team village. And I just want to acknowledge my collaborators on this project that include Sarah Sullivan, who I'll introduce and talk about a little bit more, who is the program director of the Georgia Family Planning system in Title 10 state for everyone, Sister Love, and the wonderful work that we're going to highlight with them. Dr. Missy Kotke, who is a long-term director, a medical director of one of the largest title-funded family planning clinics here in the Atlanta metro area. And other colleagues, including Kelly Comroe, who has developed a community-based community organizing approach that we're using in this project. Doug Livingston, we always need a statistician methodologist, so he's on here. And then Dr. Nandi Sheth, who is my partner in all things PrEP in women. And she's an infectious disease physician and a women's healthcare provider, and works at the Punk Center here in Atlanta. So I, again, don't need to belabor this point, but I do just want that despite seeing declines in HIV over the last decade, one place that we haven't seen a steep of decline is in the rates of HIV among women in this country. And they tend to always hover around 20. They tend to about 20% consistently remains among women. And the majority of those newly diagnosed with HIV among women are living here in the South. And something that we learned and is highlighted by Dr. Bonner's talk is that PrEP is grossly underutilized by women across all regions of this country, but especially so in the South. So some things that we have we've learned over the years, and particularly in talk about the Title 10 funded family planning network, which is a national program to support access to family planning services and other sexual health related services to all individuals and minors for free on a sliding scale in this country. We've done some work demonstrating, we surveyed 286 unique clinics across the South, Title 10 funded clinics, and we found that only about 20% of those clinics reported that they provided PrEP. So these are places that women go to and utilize frequently for sexual and reproductive care across the country, and that they are actually not really providing PrEP. And the question is that there's a huge body of literature showing that still today, in 2025, women don't know about PrEP. All women. And so we see a supply challenge where the providers aren't providing PrEP. And then there's a demand challenge because women aren't aware of this product, or if they are aware of it, they oftentimes think that it's not a product that's meant for women to take, as well as their providers. And so we are kind of saying that there's both ends of this problem, right? We need to not just focus on getting PrEP and providers aware of PrEP and offering PrEP, but we also need to start thinking about what we can do to reach women with PrEP and to do this education. So the goal of the work that we've been doing with the EHE has to really think about how can we mount a coordinated collaborative approach to sustainably address the supply and demand constraints for scaling PrEP and reaching cisgender women with PrEP in Metro Atlanta. So this is work that we could not do without partners. And so with this, in our one-year EHE supplement, we actually said, we need to get some partners. And we need to think about and start working with our partners about what we can actually do and what will move the needle. And so we naturally, because we worked with Sister Love for so long, we reached out to Daison and her team, and then we also have worked with Georgia Family Planning System, who is, as I mentioned, is the Georgia Title 10 grant recipient. And as of 2022, they were providing funds to 31 clinical sites and Title 10 clinical sites in the 4 PHE counties that make up Atlanta. I do want to just share a little bit, because a lot of folks don't all these federal systems and the healthcare networks that we have, we're not very good at describing those things, but the Title X grantee is given money by the feds, right, to distribute to these designated clinical sites that they support. And in their role as the state level grantee, they're also charged with doing things like trainings and capacity building with those sites so that they can offer new family planning and other health services in their clinical network. So they're an essential partner because they work with the Title X network, but also they are and could be a sustainable source of training technical assistance in some of these strategies that Allison mentioned earlier. So we began thinking about how can we, academic, community, and clinical network, begin to craft a way forward to work with this network and reach women in the communities where they're at. So in that 1 year, we needed to better understand what were the things that were going to be necessary to address the supply side. So how do we really sort of understand what these clinics are doing related to HIV testing and what are their needs to start enhancing their HIV testing and PrEP care delivery. And then we needed to better understand how we could address the demand side. And so with this part, we wanted to understand how we, who else we needed to include in the conversation and how do diverse communities across the metro. I mean, Sisterhood has great reach, but we also know that other community-based organizations that serve women's other needs also could be great players to come together and to use for churches or other places where women go to seek other support and other sources of information. So with this 1 year work, we did focus groups with that Title X network here in Metro, venue of trainings and technical assistance and resources that we heard were going to be necessary for these sites to be able to move the needle on HIV prevention, including PrEP. We also really spearheaded by the wonderful, wonderful community network that Sister Love has been able to foster over the time with their other community partners and to build collaborations with other CBOs so that when we were going out to think about launching a community-focused strategy, where and how could we use their support and what could that partnership look like and what would be meaningful for them in terms of their engagement. So we were able to identify 4 additional CBOs across Metro Atlanta to increase, who are also interested in participating in PrEP-focused community organizing with our group. So we after this 1 year award, we felt like we were very well positioned to move forward to launch this coordinated, collaborative, clinic-focused and community-oriented approach. But we wanted to think about what would be a good framework to help guide and facilitate this work. And so we landed on it's called the Interactive Systems Framework. The Interactive Systems Framework being inform communication and collaboration between entities who are working towards a common implementation goal. So for this, there are 3 levels to this system. There's the implementing the prevention delivery system. These are the folks that are like in our system. This is the Title X funded clinics in Metro Atlanta. Then there's the prevention support system. The prevention support system is the group of folks that work the things that are necessary for those sites to deliver the intervention. So this in our system, this would be Georgia Family Planning System. because it's their job, right, to provide these types of resources and support to the Title X sites that they work with. And then there's this third level, and it's called a prevention synthesis and translation system. And this is the arm of the system that really takes information, maybe about the innovation or the new information that they can share that in a meaningful way with the prevention support system or directly to those delivery sites to help them really get that intervention in practice. And so in this system, the role here was played by our Emory team. So with the team we have, we have a lot of ID, infectious disease knowledge. We have, more here for our team to keep up with and be on the cutting edge of the next HIV prevention technology that's coming forward. And so what we did with this system is that we were able to distill those things and then develop materials that could be used by the prevention delivery system that could be distilled to their sites. What's missing from the interactive systems framework? I didn't want to say how we're involving communities, right? And a lot of these systems, as Dr. Hamilton noted, they really were built at a time when implementation science wasn't as strong. They really focused on the implementers, and maybe not so much how do we make sure that we are engaging the end user or the community in this process. And so what we found was that we needed to supplement the interactive systems approach with a community organizing approach. And so we used an evidence-based community organizing approach that was developed by some of our colleagues at Emory, Dr. Conroe and her team, and we used that to bring in and work with Sister Love and think about the ways in which how done. And the third name of this project, which I don't have time to talk about today, actually addresses the comment that was given by the individual online, was we are using human-centered design with potential patients of these clinics to help think about how do we what would be a better way to talk about to start to integrate PrEP into these systems. But first we needed them to start giving PrEP before we could improve on their PrEP delivery. So we'll save that for next year's presentation. Okay, so this is just an example of what we ended up learning. So when we listened to during that formative years, I said we developed a set of trainings of technical assistance protocols as well as patient and provider facing resources that we leveraged within the Title X network here. So we ended up, we have 8 trainings that we heard were necessary for folks who were at all stages of PrEP implementation. So some of the clinics were already offering PrEP to patients, but others were not. Others were barely doing very much HIV testing, range of training. So not every clinic needs to do every training, but they can do the ones that are most tailored to their needs, sort of like their modules, right? Folks can take the modules. As well as the technical assistance offerings. And then what we heard that folks needed those pamphlets, the things that they could put in their waiting room. They needed them in multiple languages to really reach the women, and they needed them to show women and talk about women because they have pamphlets from many places that they could get, but they didn't highlight women in the role, like the unique things that women might be wanting to consider or ask questions about when they're thinking about considering PrEP. So we develop these tools and we disseminate them when asked for by the network. Okay, so the other arm of that has been this work that we're doing with Sister Love. And I'm going to spend a little bit of time talking about this because the community organizing piece was one in which we thought, like, how do we begin to really use sort of an organizing or a little bit of a grassroots way of getting people to understand and know information about HIV prevention as well as PrEP. And what we learned is that, women are fine hearing about it from their doctor, if their doctor is going to share about it. But oftentimes, what we heard when we did these listening sessions with the community was that we actually kind of want to hear it from someone else that I trust. Like that, like if I have a question, is this safe? Like to talk honestly about HIV prevention and sexual health. I want to hear it in my community and start having conversation. I can ask those questions and then maybe feel more empowered to go talk to a provider about it. And so we ended up working with basing on the Healthy Love intervention, which is developed by is an evidence-based intervention that's developed by Sister. And what we ended up doing was saying, like, okay, how do we take pieces of Healthy Love? And because a lot of the things that we were learning from community were part of the Healthy Love conversation, but how do we make it into like a bite-sized intervention, educational intervention that could go out and be delivered by lay people? Like just that, you could train your sister to do it, and have folks feel empowered to go out and have more knowledge to share and have a conversation about these topics. So what we ended up doing was adapting the Healthy Love curriculum into this smaller intervention that we call the Healthy Love pre-game party. And so it's meant to be like a 3-5 minute kitchen table discussion type of education that you could do. And what we then did was we worked with those CBO partners and others in Sister Love spearheading all of this. They actually went out and recruited what we call these community organizers or these change agents, right? We can train to do this Healthy Love pre-game party and give them the tools that they need. And then they go out and they hold community events across the metro area. So right now we have 11 active community influencers, organizers, or leaders, however they want to best label themselves. They can. And they are going out and finding folks in different community spaces to host these events and host these pregame parties. And since starting this in January, we've the community action team members have hosted 27 events. And we have 6 more scheduled. And we're hoping to have many, many more to come because we're going to be doing these events through the end of this calendar year, 2025. And so I just have to say, like, this is an enormous amount of work and takes an enormous team to do it. And that's why I think you can see the need to have multiple partners, but really to meaningfully engage and listen from and learn and leverage each other's unique strengths and bases. Because this is the priming and creating the demand and even just acknowledging that women, when they go to their provider, they're offering PrEP. They might not be ready that day to know something about it and have heard about it and trust it in their communities. So, like I said, this is all still a work in progress, but a couple of things that I would just like to, it does, I think, allow for a scalable, sustainable solution. If you have those actors involved, right? But you need to have that sort of that ideal place for where the trainings, the implementation strategies are going to live on to continue to interact. And then also, how do we make sure that when new things come along, those things can be refreshed? And so it is sustainable, but right and time and continue it after the fact. But leveraging each other's unique strength, that's a much easier lift to continue to sustain than it is if one person or one group's doing it alone. And by saying, like, it's all about relationships at the end of the day. And being, I think, really mindful and showing up for each other in your wait until the panel this afternoon and hearing from the other speakers. about just, making sure we're good to each other, like, especially in the hard times, like it was really becomes more and more apparent that we're not going to get through these challenges unless we can truly be good to each other and show up and do the work together. And so I'll end with that and thank you.
Questions, feedback, comments?
You said that the state distributes it to the various clinics. Who at the state level, I guess it's the State Department of Health, is accountable for making sure that those clinics that you talked about, because they're getting the money.
Yeah.
So what are they doing if they're not doing it? What are they doing with the money, and who are they reporting back to that can say you didn't use the money?
Yeah, so, yes, each state has, in the Title 10, grant recipient is up for competition every 5 years. And so in Georgia Family Planning System is one of 2 recipients. They are the largest recipient. There's a smaller one that kind of does work with more of the coastal community of Georgia. But all to say, they have these sites that receive funding have to do report around certain metrics back to Georgia Family's Planning System, who then reports it to the feds about who is doing what. Now, okay, this is where politics can come back into play, because Title 10 funding and it's what the money can be used on what services changes dramatically based on who's in office. And so this is one area where the network is anticipating some dramatic impact. Yeah, because of the new administration. They did before, and so we're imagining it will happen again. But they've never been required to have to provide that. Like that's never been a directive. They have to be able to do offer and provide, but they don't have to necessarily provide grant. And we're encouraging them to consider providing grant, especially in the EHE counties, where in jurisdictions where we know that it's vital, especially for folks that rely on the safety net and family planning network. Great question.
Your questions? One or 2 more, and then we'll.
Ladies, just very quickly, thank you so much for your work. Just a quick question around the benefits of and some of the most salient tenets of a human-centered
Design. Okay. So the benefit of human-centered design is that it's almost, I think, you're really understanding the preferences and facilitators of the end user for whatever service or product you're trying to get them to want to use. And so for this, but it is who might benefit from that. And so by bringing their voices in and having them say like, yeah, that's nice that you all offer prep, or that it's been offered like this, but really, and so hearing what would be a more impactful way that we could share or communicate about prep to that end user to compel them or to address their needs and helping them access the product. So it's really is actually, we should have leveraged it a long time ago and done it more efficiently, because marketers and business and companies that develop your iPhone, they've all been using human-centered design. So like all of these companies have been using it for a long time. And so it's now like, how can we start doing that more end user or preference driven thought process by engaging community citizens, whatever the label you want to put on it, in a meaningful way to impact health, health outcomes and health decision making.
So it's not really a question just for you, but for everybody to think about. With the current administration, have your agencies and the projects and things you're working on been looking for sustainable funding in different ways that we're gonna have to maybe start shifting the focus?
Yeah.
I don't know.
Yes. No, and I think one of the things that, and like the implementation science and working in implementation, all these folks know, you have to have a lot of flexibility and a lot of creativity sometimes, and be willing to pivot and be responsive. And I think right now with my partners, and especially with the clinical network, when they're not certain that how much the Title 10 funds are going to be available, we just sort of like said, let's just take a little pause until we know what the reality is, and then we'll start research. But we are like, what could be alternative collaborations or funding for keeping some of this work alive? I think right now there's so many question marks that it feels that the new reality is that we have to face. So yes, we're being mindful of that, but right now we're just trying to keep going until someone tells us we can't, and then we'll know what those barriers are, and we can come back together.
Thank you, Dr. Sanders.
Thanks. Were there other questions? Sorry.
After this one.
Is there one?
What days are?
Hi, everybody. Can you all hear me?
She wanted to hear perspectives on how the possibility of having reasonable options might impact the update and persistence of threat.
I can hear you on here, but I don't know if they can hear you.
Okay, thank you. They're going to need to hear me because I'm going to have to speak soon. So what do we need to do?
So I'm sorry.
Do you know who the moderator for the virtual aspect is?
No. Evan?
I think they can hear you now.
Oh. Can y'all hear me now?
Dejan, we can hear you. Can you mute yourself?
Yes, I can. And I just want to thank you, Evan, for offering my question.
Okay, so I'm just going to repeat it because there's a lot going on, so I might not have heard the whole question. What is the impact of the updated prep modalities on uptake? Was that the end of the question, or?
It was to hear, one of the questions she had is to hear perspectives on how the comparability of having modalities.
Man, we know that options are good. So the more options we can have, the better. And I think for women in particular, like what we've seen when we offer analogous to like contraception, right? Use some sort of contraception. We've seen huge impacts on reductions in unintended pregnancy, as we've seen an increase in the options for preventing pregnancy. Particularly new modalities, we'll find that especially if they're like multi-purpose options where someone can get their pregnancy prevention as well as their HIV and maybe even their STI prevention in one modality, that those things we know from acceptability studies are very appealing to women, to not have to use multiple forms of medications or multiple movies for different purposes. So I think there's really exciting options. More women maybe because they already are doing an injection for their contraception, they might be more comfortable using injection for HIV prevention and not having multiple modalities, making sure those modalities can maybe sync with the same timing so they don't have to go back to the provider, work like an off schedule time, reducing those burdens. And then I think that the option of some MPT rings that are coming out are pretty appealing and have been shown to be really appealing in other places around the globe. And so hopefully we'll see the availability of more prevention options, which I think with choice, you find you'll hit more people's preferences. And hopefully those options are multi-purpose rather than just solo for HIV prevention. Thanks.
Great. Thank you so much, Dr. Sales. Thank you for being ready to join the panel. Expedient. So our last panelist for this session is Dr. Larry Alford, who I'm so happy in that training program, and so it's really exciting. And I know one of our fearless leaders, Dr. Gail Wyatt, is very happy that we are all together. So Dr. Crawford is an associate professor in behavioral education sciences in the Rollins School of Public Health at Emory. She serves as the co-director of the Prevention and Implementation Sciences work in the CR at Emory. She's trained in social epidemiology, receiving her PhD and PhD in epidemiology at Columbia's Mellon School of Public Health. She completed her postdoc at the University of Michigan as a Robert Wood Johnson Health and Society Scholar. She graduated from Spelman, where she trained in women's studies and biochemistry. Her NIH supported research exams on reducing racial inequities in HIV. She's currently advancing implementation science of HIV prevention services in pharmacies in the U.S. Thank you.
Thank you for the introduction, Dr. Hamilton. It's really nice to reconnect here. A full circle moment. Thank you, Dr. Stanford, for the invitation here. Hosting us. I'm excited to talk about my work on use of implementation science frameworks to advance HIV prevention access in pharmacies. I am going to try to slow down and read through. I'm realizing after listening to my colleagues that I probably could put in more detail, but I'll try to make sure I get as much of the sort of how to and how I can about the implementation science frameworks as possible. So before I really start, I want to just make a note as Dr. Although I'm going to talk to you about the role that pharmacies can play in helping to end the HIV. And so what I see this work as is a combination of advancing the work, the wonderful work of pharmacists, a combination of work from epidemiologists, social scientists, and importantly, the community. So, hopefully, there we go. Okay, there we go. Black folks are disproportionately affected from HIV and less likely to receive PrEP. I think one of the biggest things that I like to know when we see these data, this particular slide, is not just the inequities. There's a success story here. This is just the past few years, starting in 2019. There's about a 30–40% almost increase in PrEP uptake for white folks. And that's a success story that we see. We don't see the same success story in the increase in trend line for Black and Latino populations. And so what we have to ask ourselves is, are the interventions that we're doing for Black and Latino populations working? And this data, this slide by itself shows no. So what my work argues is basically there just aren't enough preference to reach racially minoritized populations. We just do not have access that we need. And so what the work that I've been doing is trying to bridge that gap. So this is a map of the US Southeast. The darker red, shows, the higher HIV incidence. The yellow dots, which aren't easy to see from the room, but hopefully online, on your screens, you're able to see this a little bit better. And the disbursement of these yellow dots represent, prescribing clinics across the US Southeast. So this is taken from the locator. As you can see, they're dispersed, sort of all around, but there are some places where they're more centrally located, like in the city of Atlanta. But what we're trying to do is think of, there are a lot of gaps in the places that we could have more PrEP access. And this is what this map would look like if we included pharmacies. And there's a big difference when we add on those blue dots. So each of these blue dots represents 5 pharmacy locations. And so what we could go to from where we are is a drastic shift in thinking about how accessible PrEP could be if we were able to integrate pharmacies into the strategy for HIV prevention. So this is work that we've been doing to sort of make the case for legislators to think through how we could advance pharmacies as an HIV prevention access point. So in the US Southeast alone, we can increase access by about 8-fold, a little bit over 8-fold. This is what it looks like in Georgia overall. This is particularly salient for some of our rural areas in the southeast and southwest of Georgia. And this is what it looks like in Atlanta. Here it goes. Sorry, my favorite thing. There we go. This is what it looks like in Atlanta. If you can look the southeast and southwest Atlanta, I'm a Decatur baby, and so in Decatur, you see it just becomes more sparse. In southwest Atlanta, from here going on, you see PrEP locations become more sparse, but pharmacies maybe not equally distributed, but much more distributed than where we currently have PrEP clinics. And so there's a mismatch, right, in where we can access these services and where we really need these services, right? And some might say that is by design. This is what we would sometimes call structural racism, and that in the face of need, there aren't services that are available. Like it's not going to work. Okay, okay. Okay, so so I want to highlight that, we've been doing this work for Georgia, and we published this on the Southeast. So recently we partnered with the L2 Foundation to produce these maps for every state and major city in its entire US. And so you can go to reach.org. It's rxeach.org, and you can pull down statistics that these maps that show this for every area and show what it would look like if we were able to integrate pharmacies into the HIV prevention strategy. We know that a number of legislators have been using these data to advance policy. Shout out to Louisiana, who just passed policy last year. Shout out to Georgia, who may be passing legislation this week with bipartisan support. We're really, really excited because this could really shift the landscape of what we see as PrEP services, accessibility, hopefully across the nation, but hopefully particularly in the Southeast where we see disproportionate. You helping me out? Thank you. So it was trying to go to we don't have to go to the website, we just go to it. Unless y'all want to see the website. I can't control all of it on the website. Y'all want to see it? Okay, everything, I don't know if it's gonna go to the, if you just click on the slide, it will go to the website. It's really, you just click on the state resources and you go to the website and it'll just pull up everything. All right. I was doing it. Okay, so if you scroll down, you can see, or if you go to state resources or scroll down, you'll see that this map is here. Scroll down. And then, and the REACH initiative is really a partnership between the John Mace Foundation, Birchworth Strategies, and a number of stakeholders across the country that are really working to try to advance pharmacy-based HIV prevention access. So this is what would come up if you were pick Georgia specifically. You can also pick some specific counties in Georgia. But you could pick this for any state and take this and use this to advocate or just to have the information, including your own presentations, if you're interested. We can go back to the slides. Thank you, Evan. You don't know who? Okay, so some highlights of pharmacies. Well, in addition to them being just much more available and distributed. We know that they are highly accessible. Most Americans can reach a pharmacy. They're within about 5 miles of their home. Pharmacies have extended hours. Many of us wake up and pharmacy is open. We go to bed and the pharmacy is still open. So you can get to them at all hours. Pharmacies are nice because they're disease neutral. Folks are going into pharmacies for a number of things that may be related to HIV or may not be related to HIV, may be related to sexual health, or may not. And many times people don't know what you're going in there for. And so because of that, a lot of populations are willing to go into pharmacies and do go into pharmacies daily. Pharmacists are already readily equipped with the ability to dispense medication and have been showing really great success, particularly in HIV treatment when they engage their patients in increasing it. So we have a lot of evidence that really shows the potential impact of pharmacists, and pharmacy technicians on dispensing medication when needed to both with pharmacists, pharmacy technicians, and populations at high risk for HIV to determine their acceptability of these pharmacy-based HIV prevention models to be. An intervention that we developed to try to determine whether or not we could integrate HIV prevention PrEP services specifically into pharmacy. So this work was guided by 2 implementation frameworks and combined with each other. The first is consolidated framework for implementation research, which you guys have heard a couple of times today. The second is a systems engineering integration for patient safety. And so the reason that we use both of these Seeker is just well known for really thinking through the settings, inner settings, how the process works between these, and the organizational factors. And so we felt like we needed to really rely on strong existing implementation science frameworks, but we were working in a pharmacy, which I'm not a pharmacist, right? And so what I did was I went up to my pharmacist colleagues and said, what do you all use when you were trying to integrate your service into your practices? And SPEAKS is a very well-known implementation science framework in the pharmacy world because it really bridges like the social technical pieces of like how to integrate a service into a pharmacy that is upholding patient safety, right? And so this is why we use both of these frameworks. And I'll just walk you through what this looks like. So we're thinking about a pharmacy and we're thinking about all the work system factors that are included in this, and we sort of want to start with tasks that are implementable, right? So like what are the HIV prevention activities that we would actually want someone to implement in the pharmacy? And those are going to be very specific to the type of pharmacy, right? So there are some pharmacies who have phlebotomy capabilities, there are some who don't. And so we want to make sure that we are creating services or creating an intervention that can be able to have services that will actually be able to be implemented across a range of pharmacies. And then we go to the personnel. So the pharmacists, the technicians, who are they? What are their beliefs about their self-efficacy to be able to do this work? Their willingness to do this work. And then we move to the environment, the larger pharmacy environment. So their workflow, their space, Do they have the ability to integrate this into their workflow? Do they have a space to have private conversations and to be able to test for HIV? And then finally, this is underpinned by the organization of the pharmacy. So whether or not the pharmacy sort of organization cares about equity or stigma, or even whether or not they have existing HIV or existing primary prevention services. These are organizational things that might matter for why a pharmacy organization itself will offer these services. And these are importantly steeped within our understanding factors that we will receive, right? The community, right? Because whether or not a pharmacy can have HIV prevention activities and actually implement the matters for whether or not the community is willing to and needs those services, right? So are there risk behaviors that relate to HIV, and is there willingness help from those system for the services? So the engagement between both of these, the outer setting and work system factors, will ultimately depend on whether or not this is successful. Okay, so what we developed was a drug pharmacy study. This was a collaboration with some wonderful pharmacist colleagues, some wonderful community colleagues, all who were at the table and who we all processed the formative work together. Qualitative studies from key stakeholders to understand what would be a model that would be potentially successful. So this was led by both pharmacists and pharmacy technicians, and it's really important to include the pharmacy technicians in the model because generally they're the first contact and go to a pharmacy, the model. Pharmacists have a much higher overhead, just being realistic. So everyone felt like, well, if a technician and one, they're more approachable, but it might be more sustainable if a technician can lead a lot of services, considering that it would cost less ultimately. There was a plan for surveys for your referrals. So someone comes into a pharmacy and either any of the pharmacy staff basically say, would you like to take a survey? There's a QR code right here, just screen if you're looking to see if you're eligible. They decided whether or not they were eligible. If they weren't, they got a $1 coupon at the store. They were, and they wanted to go on, they could take a 15-minute social behavioral survey in the pharmacy. Which is set up by the farm tech or the pharmacist if they were available. That survey then determined whether or not folks were eligible for HIV testing, and they were asked to know self-HIV testing in pharmacy. Self-HIV testing as a model was really necessary given some of the legislative restraints around being able to provide HIV testing in pharmacies across the U.S. Southeast, and so that was how we landed on that part of the model. And then those test results base tests were handed to a farm tech or pharmacist where they could process. What happened on the back end was during that the farm tech pharmacists were saying what the results were going to be. If a person was testing negative, they were calling our medical director on the phone to say, we have a person who might be eligible for PrEP, just stand by on the phone. It also says stand by, we'll be sending someone to you. And so then the pharmacist or farm tech came and delivered post-test counseling, and hopefully, for most people testing negative, deliver teleprep prescription which they were able to fill the same day. And for those who tested positive, they were able to link them to care and link others to care for prevention. So I'm just going to talk a little bit about what I'm going to show you for the results. We looked at sort of survey uptake, self-HIV testing uptake, and tele-prescription PrEP uptake to sort of understand feasibility of the model. And we also assessed feasibility by pharmacy client characteristics and pharmacy staff model acceptability. So this is just a nutshell. So they're not inundated with data. But just to sort of get an understanding, because a lot of the pushback that we got when we started doing this work was, do people come to pharmacies and will they And, pharmacists are also businesses, and so they want to make sure that they can integrate services that ultimately have a return on investment for them. And so, of those who came into the pharmacy, about 70% of those were eligible and eligible to take our screening survey. No, that's our social behavioral survey, sorry. And then of those, we have a steep drop off, and who's willing to receive HIV test of 20%, and of those, about 10% actually were on. This is what these numbers look like when we look at the social behavioral survey uptake. And so HIV testing uptake by some basic demographic characteristics. We see that men are a little bit more likely or willing to take the survey. No differences by race, and we didn't capture age at that point. And then for self-HIV testing uptake, we don't see any defined demographic characteristics, which I actually think is positive because we don't want to see that any groups will be more or less likely to take those services. However, the numbers are really too small to disaggregate by for uptake because there were only having 2 people test positive who were willing to cure. Okay, so for the pharmacy staff, typical and acceptable for like the entire process. So before they start to do this work, they went through Georgia Board of Pharmacy continuing education certified training that we developed, and they felt like the training was acceptable. It was much shorter than some of the trainings that are available right now, but our lab is continuing to evaluate the trainings that are now being developed by the American Pharmacists Association and some other sort of pharmacist-led folks instead of us, because we think that their expertise is really important. And so while our training was acceptable, it required integration into the workflow, required a lot of effort. It was very difficult to get pharmacists to be willing to come online to do the training, and that was actually the bottleneck for implementing it for the longest period. That was one of the biggest barriers. The training incentives, they felt like the CE credits were sufficient and folks would be happy with those. Once they got to the model, they felt like the model was easy enough to implement, acceptable, but it did vary depending on the flow of clients in the pharmacy at that time. So when they were really busy, they didn't stop to talk about the model. So folks, because they were trying to move through. This is also not uncommon in the work that we run, and not necessarily a bad thing, because you do, like, if someone is testing for HIV, you do want to make sure that there's the time, space, and opportunity for post-test counseling. But that might present challenges. The other really, really important point about all of this, and this is really important as we see some legislation passing, the sustainability of this model is unlikely without a reimbursement pathway. So, pharmacists want to do this work. Pharmacist owners want to integrate this into their pharmacies. And some of them are doing this as a public good and because they care about the communities that they're a part of and that they're housed in. But it is inconsistently without knowing that they will be reimbursed for their time and for the services. And so that is a major barrier to this. Oh, okay. I thought, did I have another one on the slide? Okay, no, I didn't have another. Okay, well, let me just end then. That'll be easier. One of the things that I think is just critically important in all of the work that we are highlighting here is equity is at the center. And there's no, magicking our focus off of just one thing that is going to solve everything, but and reframing that with like, what is the target for all of us is inequity. Is that we just need to continue to focus on inequity and multi-pronged solution that will try to address inequity. And I think pharmacy-based stage and intervention strategies are one of the prongs in the solutions, particularly for minoritized populations. But they are not alone and cannot, activate themselves alone. We still see that promotes sustained integration of these services. So, I think all of us are trying to do work that outlives the research, it can persist, that will continue to push those. And one of the ways for pharmacy work is through the workforce. And so integrating training programs into curriculums and pharmacy schools, which is some of the work that I'm talking about some of my pharmacy colleagues, for pharmacists who care about the communities and want to do this work to improve HIV inequities. I am supported by in the world. I have immense amount of gratitude to the pharmacy clients, the pharmacists, pharmacy technicians who help inform and participate in the work. I also have a great group of collaborators and staff and students in our NIH been running my work for many years now. I'm really grateful and love to talk about this, and you can reach me in a lot of ways. Thank you so much.
Questions, feedback, comments?
So, I don't need that. So my question is, there are other states that have successfully engaged pharmacists in prep. Have you looked at any of them dealing with the barrier of compensation for pharmacists?
Yeah, so are you talking about California? Yeah, so, well, we could just talk about it. We skirt around stuff every day. We might as well talk about it. Sure. So yeah, California's data is actually what's informed a lot of my data. Shout out to like if anybody's from California on, there's a lot of great pharmacists doing work there. And their policymakers are just way ahead of the curve. They were the first state that passed legislation that allowed pharmacists to prescribe PrEP. Their original legislation didn't include training and didn't include a payment model. Their evaluation said that those were major limitations, but the evaluations have been. So, because in their initial evaluation, so few pharmacies were actually implementing because of the lack of those two things. So now it's my hope that there are more. That's yet to be determined, based on data that I haven't seen. So maybe I don't have the data, but I don't think so. But this is, I think, also a learning lesson for other states. The REACH initiative, they have been trying to develop a model policy. I think that's going to come out in April 2nd, so that folks don't basically do the same thing and have to learn afterwards, after the fact. I'm not sure that that's being picked up. It's my understanding that Georgia's bill does not have reimbursement model. I think Louisiana. It's still not completely figured out. That's the long answer to your question.
Thank you.
You're welcome.
Thank you so much, Dr. Crawford. I do have this question as you talk about in terms of sustainability. We know that the value of sustainability, we are in a teaching institution, particularly the sort of the Black institution. We're seeing on educating future nursing program as well, so we're looking at embedding and creating a curriculum to cross all the particular disciplines that we have here. So we're looking at that as we talk about our other partners, David University curriculum embedded for the R&D program on HIV in the Black community. And so I think that is very valuable as we talk about develop, training, and informing the next generation of those who are going to care for those particular populations that identify. So that is something that we are also developing here at Marksville Medicine. And so I'd like to just highlight that for our particular program. Then secondly, to talk about policy and the differences. What is different as kind of continuing on what Dr. Bryan talked about. Of course, we know it's very aggressively in spaces. The South, Southeast, a little bit different in terms of the strategies and the learning lessons that we have from Louisiana, because they're based in the South. And they have some very restricted landscape there, we'll say. So we've talked about that, we've held webinars about that, and then what's happening now in Georgia. You know, what are, you can make some of the lessons learned that we know as we kind of navigate the space of environments.
Well, thank you for that question. So I think, I mean, you mentioned a lot of things that I think are really critical. The training program. So I think Xavier's is in a really unique position, and that position really help them advocate for services across the state. But it's not without like some of the champions. So from what I understand, and I don't know all the details of your work. How, but it's my understanding that they have a lot of champions from their school of pharmacy, and then they also have a lot of champions on the policy side where legislators were looking at their areas and able to then point to some of these maps and say, look at what is happening in my area. There's nothing here, and we could really expand and shift this and change what's happening with the health of folks' health if we were to integrate pharmacy. So, I think we are getting some champions across the Southeast. And I think the nice part about one state doing it is that other states and those being states they look to as their peers. California is not necessarily a state, the states in the Southeast look at as their peers. And I think that's an important point when we think about the implementation science and policy. Which is also a field that is growing and expanding. So we think about like how we actually not just create policy, but get policy that's implemented, and then get policy that's implemented that's good policy that people can actually adhere to. There are a number of layers. There's been on a number of things. Just because that one state agrees with something, it doesn't mean that then, it becomes law. And so I think we have to think about that. Like if we really do want advanced policy in the South, what states are more right for advancements? What states can we make a stronger case, and then work from there to decide strategically what other states might policy, right? Like, I mean, let's be honest, we like to do what I always do. This is just the way the world works, right? And so there are the implementation science is a useful tool for us thinking through how to advance policies with implementation science and works for policy implementation. So I think it's a great thing for us to consider, and I think a way for us to think through sort of some of the next steps for like sustainability for some of the like very strong interventions that we've been developing that show really impactful outcomes that just still haven't just been on part of the system.
Two questions. You can say the answer right and hear it.
Hi. Can you all hear me? I think I got a message from Evan that said I could ask my question. Hey. Hi, Natalie. I just want y'all to see the glee on my face. The glee and the pride. Hey, Natalie. So I have two questions for you, sis. One is specifically about the Georgia legislation. And does it include language or does the language include contract pharmacies, online pharmacies, community-based, other words, nonprofit retail pharmacies as well? Or is it specifically for the brick and mortar stayed, larger retail pharmacies? How is it inclusive or not inclusive of the different ways that people are able to get their meds, specific to PrEP? And then the second question is specific to PrEP in a larger, more of a,
So this, I think your question, because you're going in and out a little bit, so I'm just gonna repeat
Oh.
the thing you asked.
okay,
You asked
sure.
basically, if pharmacies are included, is this just community-facing pharmacies, or does it include, hospital-based pharmacies or, delivery pharmacies? Is that what your
Yes,
question was?
yes. I'm gonna take
So
off my
this is
headphones.
just community pharmacies. So let me take a step back. PrEP pharmacy is just community independently owned pharmacies, and that. So it does not include large retail chain pharmacies. The word we are doing some additional work now. We're creating essentially 300 pharmacies now in the US Southeast. So that does include both independently owned and chain large retail pharmacies. For those folks, we are basically asking all of the questions, the acceptability, feasibility, raise questions around whether or not we're trying to assess their readiness to implement on plans. But the PrEP pharmacies, which just independently owned community pharmacies, which are really pharmacies that are doing this.
Awesome. Thank you. The second question is a little more generalized, just in terms of thinking in the current climate that we're in. And one of the concerns, of course, in terms of being ready for and having a strategy for, is when we are able to, because I believe it's going to happen, when we are able to access PrEP through pharmacies. Are we also looking for ways and strategies that'll make sure that there are exceptions or exemptions from pharmacists that may refuse services to people based on the new restrictions in public health codes, which I also think is probably is a high probability.
Can you repeat the last one? Are we also looking to see if it was integration of something with them all? And I'm sorry, I didn't hear you.
It's okay, and I'm apologizing, and I'm worried about sound for the remarks I need to make, but we'll be okay. I'm literally just thinking forward about how we prepare for the refusals that will come from pharmacies that don't want to serve key populations, don't want to serve adolescents, don't want to provide PrEP to LGBTQ people, to people who inject drugs. That's because that's right now some of the basis of the Braidwood v. Becerra case, right? In terms of insurance companies, this may be extended to pharmacies.
This is a really good point. So I'm gonna be very honest with you about what I think is, like, as we see this legislation moving, what I think is gonna happen. Because I think that informs your question. And what I think what I'm trying to do to combat some of it. So for example, Georgia policy is not going to have a reimbursement model. So what we're going to likely see, which is what we saw in California, is that the pharmacies who can implement with, and those are the same pharmacies on the north east of our city who are high income, who have lower mobility, who likely won't even, come into contact with our stigmatized populations, and we love them and we're in care for this work, right? And so we are going to potentially have an issue. That's if we don't engage community and lower their entry or implementing these services for our pharmacies that are in our neighborhoods. Now, you are right. There are still going to be some pharmacies that do not do this work, that do not see this as a part of their workflow or their mission and what they do. I have said this time and time again, we don't need all of them. There's 5 pharmacies that represent every single one of those dots. We won't get all, right? Everybody just won't do it, but what we're trying to do is engage some community folks who can lower the barrier of entry to provide pharmacies with the skills that they need to be able to implement this model with lower costs. So that it's not like they have to have the same resources in a pharmacy in Alpharetta. Where we already have vet clinics and they already have services and resources. Now, the bigger picture question of that is, what are we going to do about discrimination moving forward across a number of systems and organizations and structures? And I think we're going to keep doing like everything we've been doing in this fight. I mean, I don't know what that looks like. I'm gonna be blind on you.
Yeah.
Yeah. I mean, we're gonna be relying on folks like you. And every time I say, you remind us the history of this is this, and you tell us. And I think we're gonna just have to keep like having that historical knowledge in these rooms to remind folks of what we did, because this is not the first time that we have seen disenfranchisement and marginalization of our people.
Thank you. Thank you so much.
So, as tired as I am, I know we need to rest. I am a part of the NAP industry. Hopefully everyone is. I'm not, I'm in a place where I'm not, sad and boo-boo. Like I know we have people that know what to do and know how to tell us what to do. So I just don't, I feel like we're gonna figure it out at some point. I'm gonna sleep too in the meantime. Right now I'm just kind of leaving resting as much as I can. But yeah, I think there are a lot of big picture, but also specific things that are within that we have to figure out how we still make sure our communities and folks that we need to have these services and must get access to them.
Excellent. Thank you.
Good afternoon, everyone. I'm Michelle Allen, and I feel like this on. I have a comment. It may provoke you to respond, but I want to start with a thank you. And Dr. Lawrence, you tapped me into think about it. So I love the West Coast and I love the wonderful things that come out of it. But when we look at best practices, we also have to consider best budgets. And for historical reasons, the resources are not. It's a counterpart of you to talk about the fact that the real issue is the land. And then that will take you to the fact that people are unsure. And so you're going to find the commonalities are states that touch each other look a lot. Like when it comes to Medicaid expansion. And the sad part that you allude to is the same group. It's the same group. So the prioritization of this work is extremely important. And especially if we lean into some of the things that got us in the first place, like the urgency of now. We want to, the blue dot now my face. You know, you could have just said, look at the dot, but you said it's really bad. That like I think I want it in my phone. Whatever people say. And then I'm just gonna send it back, and then I just know that it's needed and important, and we're all in this together. We really are. I just wanted to give you an encouragement. And as a Georgia girl, maybe I'm biased, but I think we are doing a good job with the limitations and the lack of funding considered against some of the other places they do say.
Can I say thank you to you, because You were with me in the beginning when I was talking about these numbers. You were, thank you.
Well, I also want to say thank you. I want to say thank you for the project because years ago, when I was charged with going into the community to set up unconventional spots where we can provide HIV testing, I used a pharmacy rather, a pharmacy right next to a liquor store. All right, and I felt like, hey, there's my traffic over here. Let me go in here and offer HIV testing. And of course, we didn't get a whole lot of people that said, yeah, I want to be tested. But I thought, well, this cannot be a failure. But it did take off right then. So to see that there's a project that are including these private pharmacies, we can't just have testing once a year at Walgreens or all these CVSs or whoever that are engaging on the anniversary of National HIV Testing Day. We have to utilize these resources that we have. And then people use pharmacies as their doctors because they can't always get to the doctor. You know, and if we have in the pharmacy where we can test for our blood pressure and test for our glucose levels, and surely we should have some way of testing for my status or my sexual an infection or something, singular thing. I just think we have to reach. And again, I go back to community. I go back to the community organization because if you can't pay the technicians, surely you can pay the community organizations. So anyway, that's all.
I'm gonna have you come and present for me the next time. I don't even need to talk.
I just, as everybody before me has said, thank you, because to me, this is a great intervention that should be in rural areas.
Yeah.
Because they don't have a lot of resources, and we know sometimes they have other comorbidities when they stay as pharmacists. So I think this is a great intervention, and anytime you need help, just shout and move to the text.
Thank you. You have any more questions?
Let me add my thanks to the beautiful presentation and work as well. My name is James in the Department of Education and Surgery, and we had a couple of partners to it. But my question is that this year, the School of Medicine celebrated its 50th year of its anniversary. And we've done some things in the community. Like we hosted this particular event, but have we really been present in the community? Wherever located, people who look in a number of the same places they work. And I ask that question because I was born in Baptist movement, but if I look at all the churches in the country, the Seventh-day Adventists have a distinct health ministry as part of their spirituality. And so how do we get our churches to be fully engaged in health ministry? And I don't think that we have to look too deep into the Bible to see what Jesus did in terms of health. So how do we do that? Thank you.
Now, I will say, and I apologize, it's gonna, got a blank on it, who the researchers, their names, but there are some folks attempting to use implementation science frameworks to advance HIV prevention in churches in the South. There's folks in South Carolina that are more doing this work. Latrice what's her last name? Latrice Deshawn in Memphis. I don't remember the people from South Carolina, database innovations around HIV prevention for quite a while. I've seen this in my church where they've done HIV testing. I think the difficult part is integrating. So we see a lot of churches like ministries integrating this in sustainable ways of this offered all the time. I think it is difficult because all churches, like other organizations, have limited resources, right? And if there were a way to integrated for thinking through the long-term sustainability of those measures. But I apologize because I don't know the literature in that area. I think it needs to be a little bit better. I wish we could give more. Maybe some of my panelists can. But thank you for your question.
Thank you all. Let's get this. Thank you all. Thank you all. We have more to come. So we're asking that as our panelists, our next panelists come up. Thank you again, everyone. We're going to ask Dr. Sales to shift from her panelist position and come up as a facilitator. And what would you go on if you have to take it back to a break or need a snack? They're over there. Lunch is coming out so shortly. But I know Dejan Yano she's sitting already. She's ready to come up and so I know she has a hard stop that she needs to do. So we're going to ask our next set of panelists to come on up. And you can take that break while the speaker is talking. That would be great. And so now we'll transition over to the second panel, focusing on engaged in implementation science. And we have panelists / facilitators here, Dr. Sales. Thank you again.
Thanks for being with us as we transition. It's not good to see you now. Okay. It is my great pleasure to be the moderator of this second panel, where we're going to really focus on engagement and ending the HIV epidemic. And at first, speaker from this panel, Dejan Diallo, who is a recognized visionary and advocate in 1989, and it was the reproductive justice organization focused on women in Southeastern United States. She's a proud member of In Our Own Voice, the National Black Women's Reproductive Justice. She advocates for sexual and reproductive health rights and justice in public health and the ACNA and AIDS National Coalition. She is also a member of several bodies of influence, including the Women's HIV Prevention and Sexual Health Scientific Committee. Okay, keep going. Okay, the HIV Prevention Trials Network, as well as I think I've been or at a conference where Dejan isn't leading something or part of the initiatives. So she has during the 40 years that she's been working in health justice, women's liberation, and human rights. Dejan continues to learn and lead in the fight for sexual, reproductive, gender, racial, and economic justice, transparency, and integrity. I just want to note, as you see in her bio, she's also originally from Fort Valley, Peach County, Georgia, and she loves traveling, music, and storytelling. And I just don't having a course to say over to Jason, and she's gonna share some of her wisdom with us today. Thank you.
Well, thank you, Jessica. I hope I'm heard okay. I'm excited to be here. I have worked really well to be here. I am sitting, first of all, I just want to say thank you to everybody. It's been really great. Courtney, you look so good. I'm excited for you. I love and know everybody who is on our panels today. Dr. Hamilton, I don't think we've met in person, but I follow you. So I'm extremely happy to be with you all. But I will say that I am sitting, it's cold in here, but I'm sitting in a room at the Mobile County Health Department because I'm about to go into a room and spend the next couple of hours with a room full of people living with HIV, learning about how to care for their whole selves. And so, as much as I miss being with you all there in Atlanta, you all are in there together, you are together. I am here with a bunch of people who are also my tribe, just like you all are. And so I'm really grateful to be in body and in community with these people who depend on us to get it right. So, so having said that, I wanted to also say I tend to overslide all the time. So there'll be a lot more slides that I probably don't directly address, but as long as they're a part of this recording and you can have them later, there may be something useful, even if I didn't speak directly to them. And that's because I really wanted to shift just a little bit and take a moment. And there's a connection in this moment. We haven't stopped for just a second to honestly acknowledge what is happening, specifically in sub-Saharan Africa and in the global South, where over 10,000 grants have just been shuttered overnight permanently, which means that there are thousands of clinics, thousands of service providers, thousands of U.S. government people who have been living in and living with and serving in communities are looking into an abyss. And the fact that where we are right now is acknowledging the solidarity that's needed, particularly with the women and girls of Africa, because the very reason that they are the very reason that we are able to sit here and talk about PrEP and PrEP availability specifically for women and for girls, because until very recently, there has not been a study, a clinical trial that included cisgender women in the United States in any HIV prevention clinical study. This is important for us to get it right, but it's also important for us to remember and be grateful and to stand in solidarity with all those women and girls who are being directly affected and impacted, not to mention the key populations who are basically being erased. Not basically, wholly being erased by our government and giving permission to other European governments, as well as African and other governments that already have restrictive and punitive laws around some of these populations. So I just wanted to acknowledge that. I wanted to bring that in the room. I wanted that to bring that to our minds and our spirits because there's no business as usual. Nothing is normal. And wherever we go, we're not going back to what we were. And so being prepared with these kinds of conversations is really important. My original intention, Evan, if you want to move to the next slide, my original intention was to really talk about how we should continue to expand and embrace and even dig deeper and drill harder to make sure that community engagement is an ongoing part of implementation science. I think across all of the different types of science, the implementation science has the closest relationship to. I think Jessica's talk has laid that out. Courtney's talk has laid that out. Has spoken, implementation science speaks directly to community and community engagement in terms of making sure that whatever drugs, medicines, products, social behavioral interventions, whatever it is we're offering, that it is what is actually needed. That's a part of what makes equity equity. So that's my short definition that I borrowed from Carnegie Foundation for what community engagement is, recognizing that it is a mutually beneficial exchange. Without community, no science is complete, basically. Next slide. And I might have to open mine up because these slides are moving slower than I am. So in that context, just to give you a little bit of a look backwards at where community engagement has come from, we have had to fight for inclusion from day one in the HIV response, starting with having to protest and demand using science to make sure that whatever was being developed around HIV or AIDS at that time was inclusive of women, because it wasn't. Last year, 24, actually marked 30 years since the decision that included, 1994? Yeah, that the CDC modified its AIDS guidelines to include conditions that were specific to women who were not getting diagnosed with AIDS because they may have had an opportunistic infection that wasn't included in the guidelines. Cervical cancer being at the top of that list. But there are also opportunities for us to become well-versed in research so that we could back up our demands. We learned that from the Denver principles and from Treatment Action Group and ACT UP. And ACT UP is getting its ACT UP back up. If you saw the news of what happened in the Capitol yesterday, should have been there. That there are people living with HIV who galvanized systems of research, galvanized how policy got done. The rapidity of how we move from molecule to medicine nowadays is largely in part of the science of HIV and what we have learned, and how community has been a part of disseminating and implementing the outcomes. And of course, the advent of community advisory boards increased during that time. We went from looking at this struggle of pushing and pulling to make sure that research is done right come the 2000s by producing the good participatory practice, which is now a normal guideline for community engagement that the NIH has attached to just about every single study that they fund. It increased demand for transparency in research, particularly transparency with communities. This is why now you have community slides that are attached to presentations that come from scientists and researchers funded by the NIH. It's why we have, for example, advanced community engagement to make sure that from the time protocol is being decided to the time publications are being written, that community is involved. And of course, we've come to a day now where community advisory boards are not enough, and that community engagement itself has begun to and needs to continue migrating from the actual research sites, the academic institutions, the industries that are conducting the research. The community engagement segment of all of that needs to be in community, with community, by community, and resourced in community to be a part of the studies. Where Sister Love comes into this, next slide, I'm hoping that we're on the slide that says Evolution of Sister Love. My slide set on screen is slow, so it's coming in slower than I can see it. In terms of Sister Love and our role in community engagement, for a quick story, Jessica talked about our Healthy Love Party. The Healthy Love Party was actually, I wrote it up, I created it in community, with community, by community in the late 80s. And it's still powerfully popular and effective today, by the way, with different adaptations. The Healthy Love Party was a homegrown intervention. And we developed our own curriculum, we were able to do training of trainers. We had key opinion leaders review our facilitators manuals so that we had an engagement. We had the voices and the support of community for what we were offering in terms of the curriculum. In the early 2000s, late 90s, early 2000s, the Centers for Disease Convention in the social and behavioral context created an initiative around making sure that evidence-based interventions were being supported, funded, and diffused. And we were learning that there were these other interventions that now, in order to receive that kind of resource or support from the CDC, we had to implement these other interventions. when we knew we had one that worked for our community, in our community, and by our community. And so we engaged in our first ever opportunity to do community science. We led and partnered up with Clark Atlanta University. We partnered up with our CDC partners in the Prevention Research Branch, and we conducted our own 2-tiered, 5-year randomized controlled trial to evaluate the Healthy Love Workshop, which is how it ended up in the compendium of evidence-based interventions. I bring this to bear because that was the beginning of us realizing that we had the capacity, we had the opportunity, we had the capability, and what we needed was the capacity to build out a robust research arm of our work so that what we were able to do is be a go-to partner, if you will, for those researchers, research partners, and academic institutions in our midst that were interested in the same issues and the same populations as us. And of course, we have survived, like many have, but there are many who have not, have survived that pivot from the social and behavioral specific interventions to the biomedical. And where we are is making sure that they're intersected and and engaged. Next slide, please. So some of the tools that we engage around communities with research is, and I think, I haven't seen the face, but I think I've heard the voice of the one and only Damaris Henderson, who might be in the house. I think I heard her, who is a historical part of helping us set up our relationships in this regard. So participating and or leading and organizing community advisory boards, what we now call community accountability groups, the Community Liaison Council, participating with our CFARs, participating as partners in CBPR, doing our own research. I'll talk about that in just a moment. Community involvement in terms of a community of practice, and a lot of those tools that are necessary in that community of practice are in that circle where we talk about the roles of CBOs in community-based engagement. And then, of course, making sure we strengthen our strategic community partnerships and participate in IRBs. And we want to make sure that we're helping and are a part of the growing of community-based institutional review boards as well. They're a little more nimble, a little more flexible, a little more directly related to some of the issues that happen on the ground with regard to community research than we have had success with in terms of our institutional IRB partners. Next slide, please. So I use this because my mama always said, have you looked everywhere when you couldn't find something that was missing? So I asked the question, in terms of where we are with implementation science, have we looked everywhere to make sure that creating and expanding the opportunities for people to take care of themselves, to prevent HIV, to expand that understanding of how to prevent HIV, to be more broadly engaged in prevention across all of their health concerns. So have we made sure that all of our studies, implementation science included, are inclusive of social, behavioral, and structural research so that we can measure the systems that either impede or facilitate greater access and equity in the services and in the interventions? Are we making sure that we're compensating collaborations with community-based organizations in sustainable ways? Are we also making sure that what we can now call essential populations, that will be a combination of key populations and priority populations that now cannot be named, especially in the global funding space. But are we making sure that we have bodies and subgroups that are representative of all the essential populations? And I call them essential because these are all the groups for whom we will have to achieve near zero community viral load. And we will also have to make sure that we've achieved a full expression of viral suppression, as well as sustaining HIV negative status because of PrEP and PEP. And have we modified our exclusion criteria in studies to make sure that we are not discriminating against people who could become pregnant, people who have a different gender identity, or a non-conforming experience? This is critical. Moving forward, I just, in terms of where the community has been and where we're going and where we are as Sister Love, is some of what's already been stated by others. is that we have to be prepared for participation and support, that community organizing is what we do. So we bring that into research, and it's now a part of implementation science, as Dr. Sales has already presented to us. Building greater relationships with our researchers, staying engaged with the networks that are necessary, making sure that research literacy, health literacy are combined and are going together, communicating the needs of the communities and the individuals within the communities, which means listening to their stories and centering them is important, as well as affirming their roles for advocacy and accountability and accessibility that are ethical, equitable, and just in the research. Next slide, please. So one example, this is just a list and it's incomplete because I ran into some issues and I needed to get this in on time. So I'll mention a couple of things that we're engaged in, like the Healthy Love pregame is a part of the initiative, but we're also in this study with It Fits. We participate as the community engagement coordination site for Erase HIV, which is doing the HIV cure work. The Max Y study at Emory under Drs. Sheth and Ofodokun. We are the community engagement partner there. She's Mobile with Dr. Miranda Hill, which is looking at women in transition, moving from one location to another, and what's the impact of their ability to access and ongoing health care and preventive services without disruption. Of course, with Dr. Bonner, we've been in a couple of studies, Empower Her. I spelled that wrong, Dr. Bonner, I apologize. And Improve, which focused a lot more on mental health. We conducted our own study, 2 different studies focused on access to medication abortion in the state of Georgia in partnership with the Emory Rise Center. And currently we're engaged in putting together a plan for our part of working with Purpose 3, which is the U.S. side of implementation in terms of lenacapavir, or the once every 6 months or twice a year injection for HIV prevention, which, if you haven't heard the news, was stopped for success, not futility, was stopped midway for success in the fact that over 2,300 adolescent girls and young women who have been involved in that study achieved zero new HIV infections in over 3 years of participating in the study, which essentially means that in the study, the lenacapavir showed that it was 100% effective in stopping HIV. And that's why I asked the question about how we're preparing for new strategies. Next slide. I'll skip that one. Next slide. Before I close, I want to come to a specific question, because we've talked about implementation in the context of sources of sites. We've talked about implementation in terms of design of services. We've talked about how we're expanding access, like through the pharmacy movement, or the pharmacy approval movement. But we don't talk as much about language and how that's come to us. And I just wanted to land on this particular piece before I close. Think about where we are with we've heard the data around women not accessing PrEP. I think a large part of the stigma, the lack of focus, the lack of centering, the lack of information, the lack of clarity around coverage in terms of who pays for it and for how long, all of those have demonstrated through study after study after study that these are real key reasons. But there's also work that tells us that language matters and the message matters. And just park this for a minute and then I'll get out of your way. When what was it called? HPTN 052, which initially was a study that for treatment, now this is looking at the continuum, the care continuum, but for treatment, the research was titled HPTN 052. When it went into clinical space, we knew it as treatment as prevention when it went into implementation science. But what happened then was there still wasn't a lot of understanding or uptake. People living with HIV were not getting that information. Women especially were not getting that information from providers, from community, from their own efficacy in terms of looking for that information. It was when community decided when community understood what treatment as prevention meant, how you achieve viral suppression